We'll go ahead and get started. I know that folks are still kind of coming in through the waiting room, but we'll get started in the interest of time. And Vicki, if you wouldn't mind watching the emails, I think folks are still trying to get on the links, and we'll try to, because I'm seeing some emails come through asking for the link. So I'm going to try to field that as well. But for all of you already on the line, thank you very much for joining the CTS's State of the State as we make it through our surge in the ICUs. My name is Asha Devereaux, and I'd like to welcome everyone to I think this is our 5th session that we put together along with Dr. Dennis Amundson and Dr. Christian Sandrock, who really are in the thick of things in the ICU in Northern California and Southern California. And we thought that this would be a way for us to share strategies to get out of difficult situations as we faced problems that happen with surge, like oxygen issues and running out of supplies. We had all served together as part of a mass critical care task force. CTS, the California Thoracic Society, has been around almost 100 years, and we are a society that enjoys membership support as well as support from some industry partners who we'd like to thank for helping make this platform possible. Before I get started, I just wanted to do some housekeeping announcements. These sessions are being recorded. Many people have requested information regarding prior sessions because they couldn't join. I know this is a difficult time. The board last weekend discussed trying to move it and shift it. We've got kind of a 50-50 response. Folks liked it. They feel this is more traditional and it's become a routine for them. Others said that, well, the day is so busy anyway that there wouldn't be any time during academic conferences. So we'll just stick with it, but we'll try to stay on time. Many people said, well, we want it to last longer because the conversations were so terrific. If you have to leave, no one will be offended. Stay for whatever time you can make it. Everybody's been muted upon entry. And so just remember that if you need to speak. This is your forum to share ideas, thoughts, questions. We are honored tonight, besides Drs. Amundson and Sandrock, who will be moderating the rest of this discussion. I just saw Dr. Neil McIntyre enter the participant list, so we're honored to have him join us this evening from North Carolina to provide his wisdom and expertise around some of the issues and burning questions you all have. But Dr. Burr and Dr. Qadir from UCLA are experts at their institutions on mechanical ventilation, and we'll be discussing some strategies and topics regarding BiPAP and things that we face when we are in a surge status. We've asked Dr. Carolyn Hendrickson from UC San Francisco to discuss compassionate extubation. And we're honored to have Dr. Bernie Lowe from UC San Francisco to give us his thoughts on some of the ethics that we may be facing. One of the things, as with every single session, I always point out that when we're in a crisis or surge status, we have to partner and work together, and that's part of what we're doing this evening in information sharing and education, making sure all of these pillars are formed. And now we're finding the headlines yesterday from BMJ is what went wrong with all of the political part, and they're starting to point fingers up there for what happened in healthcare. It's not happening here, but I think that this is going to start percolating in headlines, so I just wanted to give everybody a heads up. But, and then I don't know if Lori Laird is on the line, but following last week's conversation by Dr. Morrison Tapson, thank you very much for sharing that wisdom last week. UC San Francisco has posted online their a document regarding their thoughts on therapeutic use of use of therapeutic anticoagulation. So I just wanted to give everybody this update that it is currently something that they are going to be starting to use in select populations. So with that, I'd like to pass the mic on to Drs. Amundson and Sandrock. Thank you.
All right, perfect. Well, welcome, thank you. And I'll start in the north part of the state. And again, if I'm moderating and you see me disappear, I just sneak off to the ICU every once in a while, and we don't have a camera there, so I'm back in my academic office for this part. And Neil, it's great to have you. Hopefully you can hear Neil, and everyone knows Neil, whether it's directly or indirectly. He's known in my fellowship as the guy who writes the really hard Seek questions. So the one questions in Seek that make you feel phenomenally inferior, Neil is one of the two people. The ones that are easy probably belong to me, but Neil is a brilliant man, so I'm very happy he's here to give his input as well. So up on the, at least on the north part of the state, I certainly would welcome anybody, Drs. Hendrickson or Laird, for chiming in, as well as what's happening in San Francisco. I think it's really not a big change other than we've had a slight decrease in numbers. We're looking at how we're counting our COVID patients in general, because obviously, as we talked about in prior meetings, if we discontinue isolation on our dashboard, they disappear as a COVID patient because they're not part of the infection prevention side, but they obviously still have all of the long-term sequelae and resource use that comes with that. So we've rechanged it so our numbers are a bit more accurate. However, our number of COVID admissions have been on the decline. Our ICU discharges have increased slightly. This past week, we were able to decannulate 2 of our patients on ECLS, including one just a few hours ago after I clamped them overnight. So this is actually good news. So I think we're seeing things moving in the right direction, enough so that our command center meetings every day are really obsessed with the vaccination process. And my input on the command center is waning, which is great because that means it's less and less ICU care. And I know our surrounding hospitals have had increased capacity. We're able to both transfer patients out and accept transfers in. So as a whole on the inland portion, we've slowly are digging ourselves out. Some of our hospitals to the south, whether it's Lodi, Memorial, and Stockton, have also had some improved input. And if anybody in UCSF wants to chime in, please let us know if anything's different or you guys are better down in San Francisco.
We are also seeing a plateau or a decline in our numbers and shifting focus to vaccinations.
Yeah, perfect, which is good. So anyway, the good news, Denny, as we transition to the south is we're kind of boring. So that's great. Oh, I see Lori's here, which is great. And Lori just notified one of our long-term patients who was with us with COVID actually was transplanted at UCSF earlier this week when we sent him down, which is good news for us. So anyway, Lori, feel free to chime in. And we did show your slide with your anticoagulation changes, which was great.
Yeah, I put the post in the chat, and I agree with Carolyn.
Easy and fast. All right, Denny, over to you.
Oh man, we've got people from LA sitting in this group that I'd love to hear from, but I can tell you what happens a little further south. It kind of mirrors what you said, Kristen. Is our case rate has gone down, except on the border where we're still about 24. We've been as high as 40%. It's now about 24% for case rate. In our little place in San Diego, with about population of 3 million, we're pushing 250 odd thousand cases, and we're around at 2,800 deaths. And I see LA is, if you take their 10 million population and factor it out, we're pretty close. You guys have about 17,000 deaths up there. Here in the further south, Riverside and Imperial counties really hold sway down here. They're still running, Riverside's about 2.3 million, and their deaths are around 3,500 or so. So they're still picking it up and putting it down. In the Scripps system, Also, Kristen, we're down. We're got about 300 now in the system, 90 down in the ICU, which is, gosh, I think a week ago we were 120 or 150 or something like that. So we've dropped. 85% remain on mechanical ventilation. We're not, we're still have fairly long ICU stays, but they're dropping, and we're getting more non-COVID in the ICUs. At least in my ICU right now, I have, out of 20 of the beds, I have 13 COVID, all are intubated, but same, we're starting to see a decrease in the hump. We'll just see what happens in the future. So that's what we got down here. Anybody from LA got any information?
Hi, this is Nita Kadir from UCLA. Our numbers have been coming down nicely. I'm not yet convinced that this is going to be a lasting trend, but I suppose I'm not a glass half full person. So between our two campuses, we have 104 inpatients. 40 of them are in the ICU. 11 of them are on ECMO. We've gotten quite a few requests from ECMO from our neighboring hospitals. So, you know, we're in better shape than we were a few weeks ago, certainly. But with the, you know, reopening, we shall see how things go. Our, you know, hospitalization levels in Los Angeles are still substantially higher than they were when the stay-at-home order was issued. So we'll see. Vaccination efforts have picked up. The pace has picked up a bit, so I'm optimistic about that.
So I'll report from the eastern side of the country here. One of the most striking things we've seen here at Duke is the incredible drop in the caregivers' conversion to COVID. We have the majority of our healthcare staff now vaccinated, at least with the first dose. And it's been a almost 80% drop in the COVID conversion rate among healthcare workers in the Duke Health System. So I'm very optimistic about that statistic.
Yeah, that's interesting, Neil. We've seen the same here at Davis. And we just, a few hours before this, right after that, we were able to decannulate that one patient. We reviewed, and this is my ID side, we looked at all of our viral respiratory panels because we're still getting those along with the combined flu and SARS-CoV-2 test. We have not seen a single case of influenza here in 2 months. So it's pretty impressive. So it just lets you know, not only vaccination, which has been nice among our healthcare workers, is all the masking. So I swear I'm probably never going to wear a mask on an airplane again, even a decade from now, or never not wear a mask on an airplane from a decade from now. But we have seen almost no influenza, and we're at about 8% on our positivity in our viral respiratory panel compared to a year ago. So pretty impressive.
How's Vipul? You're at Fresno. How are things going there?
Yeah, no, I just put in the chat box. It's the same. I mean, our trends are gradually and consistently going down, so the numbers are getting better. We haven't seen much flu either. There is zero, like was mentioned. So the last couple of weeks, the numbers were up only because we had that initial flux of patients that just want to leave the ICU, the COVIDs, but the past 7 to 10 days are when we get 10 admissions, we're only couple of them are COVID. The rest are something else, even though they may have had COVID or they're COVID positive, but they're not coming into the ED because of COVID. They have like something else going on. So yeah, I'm hoping it'll stay this way.
Yeah, I can update us really quickly about what's going on at UCSD. So UCSD, we have our ICU is about 90% capacity, which is a comfortable area for us. We have about half of our ventilators that are in use are COVID patients. And we have about 1/3 of our total number of ventilators we own in use. So we're actually, although it's certainly busy, we're in a pretty comfortable state. UCSD has been very involved in the vaccination administration throughout the city, and we've actually given out about 120,000 vaccinations already. So That's probably, I think that whole vaccination effort is responsible for some of that dip. We've got about 82 COVID patients in-house. And as I said before, about 1/4 of those, a little over 1/4 of those are in an ICU. So we're like everybody else, looking pretty good, but cautiously optimistic. But we got here by being too optimistic. So hopefully we're going to get away with this.
Hey Tim, are you also helping out in Imperial Valley? I thought some of the people were going out there to help there. And do you know anything about that?
Yeah, so El Centro is actually in the UCSD system. So our faculty go out there, and we've got a good relationship with them where they'll send people. They've got a really very limited ICU capacity. So when they reach capacity there, they shuttle them over here. Probably the same thing that the Sharp and Scripps system do with their southern hospitals, that once they get into trouble, that we're the first call for those guys.
I think we saw Chuck Wright, you were the CMO of the alternate care site in Imperial. If you want to share some of the numbers that are going on in Imperial, if you know of them.
So unfortunately, I don't have the current numbers. On the call this morning, it sounded like Pioneers was around 69, if I remember right, and El Centro was below 100. It was like around 89 or 90. So certainly down from when I was there 3 weeks ago. El Centro was running 130, 140, 150, and Pioneers was over 100. So they've gone down, I'd say at least, 30, about a third at least, which is a big change from when I was there.
Somebody else?
Yeah, it's Elon from Sharp Memorial. Our numbers are about the same. We've got 106 at Memorial, 400 total at Sharp. We're still overflowed in our PACU for ICU patients. We've got 9 people on ECMO across all Sharp hospitals right now. Not all of them are COVID-19. So we're definitely busy, but the new admissions are definitely slowing down. So hopefully we'll be able to staff down soon.
Thank you, everyone. So Denny and Christian, let's get to the topic of the evening. All the burning questions, yes.
How to keep them off ventilators.
Yeah, perfect. All right, well, Denny, did you want to start with some of your questions? And, I know people have submitted a number of others as well. And I think this is a great chance for us to hear from Drs. Burr and Kadir. And
I think so too. Why don't we let them, they have had opportunity to look at some of what we're interested in. We'll throw the ball their way.
All right.
So Dr. Burr, if you want to start, just give us a little bit about yourself, and then anything that you find that you would like to talk about in a nutshell.
My name is Russell Bohr. I'm an assistant professor in Pulm Crit at UCLA, where I also did my fellowship. And I actually am primarily a healthcare delivery researcher, so have always been somewhat interested in strategies to reduce ICU and hospital utilization among patients, primarily with chronic lung disease. But when COVID started, kind of ended up becoming our resident expert in crisis standards of care and ventilator allocation policies. So that's my main area of interest, but certainly as a practicing, intensivist since the pandemic started too, we have, I think between Nita and I, some good experience that we could share with non-invasive ventilatory management, including high flow oxygen systems. And I'm looking forward to kind of hearing some questions from the group. I didn't prepare specific remarks. I was mostly interested in seeing what people wanted to talk about.
Well, I have my list. You can start there. We've been also, some of the other people have talked about the barotrauma risks that we've been seeing on both in our ventilated, but also more so in our BiPAP and non-ventilated patients. And have you noticed the same thing? And have you got a remedy for it?
I think I'll speak to my experience first, but then Nita is far more of an expert in ventilator management and ARDS than I am, and she taught me probably 80% of what I know about it at this point. So, but you know, I do think I am always a little bit worried about that for sure, and especially as people are augmenting tidal volumes and air trapping a little and kind of breathing back out while the breath is being delivered. That's when I become most worried about it. And we know from prior study that you know, non-invasive ventilation among patients with primarily hypoxemic respiratory failure, primarily the outcome was delayed but necessary intubations in patients on non-invasive ventilation. And so I'm always a little hesitant to say, oh, they're not doing well on high flow, let's put them on, you know, BPAP or Cpap or whatever it may be. But also recognize in a crisis, we can't let perfect be the enemy of better. We've fortunately been able to avoid ventilator shortages, at least at most of the UC hospitals. And I'm not sure if there have been ventilator shortages at some of the outlying and community centers, but you know, we haven't had to use things like non-invasive ventilation because a ventilator wasn't available. Now, it's interesting is we have run into a fair amount of problems, and this has particularly been true over at the VA, where I do quite a bit of my critical care time these days. A lot of ventilator hesitancy, I think, that's been propagated in part by a narrative that's if you get intubated and you have COVID, you're going to die. And you know, I think one of my big concerns as a researcher primarily is did we create a reverse causation narrative where it's really people who are really sick, of course, are the ones who are most likely to need to be intubated, not that the ventilator killed people, but that both things were true. They needed to be intubated and they were likely to die. And then we get into the question of, you know, did delayed intubation result in worse outcomes? And I think, you know, some of my big concerns are that without an adequate PEEP strategy to recruit lung and or the ability to reduce oxygen consumption by you know, using sedation as a tool or even paralytics in some cases, that we do sometimes have to give people really high FiO2s in order to keep them even in a low safe range. And there is, you know, something to be said about oxygen toxicity, I think, that can propagate things. And that may be some of the reason, and I'm just, you know, hypothesizing, but some of the reason why we see these people that have languished for a really long time end up doing really poorly once they finally get intubated. But again, it's, you know, I think one part kind of physiology textbook, one part like observational retrospectoscope. And I don't know that any of us know for sure. And I don't think we'll ever do a, you know, randomized controlled trial on prolonged non-invasive ventilation versus invasive mechanical ventilation in SARS-CoV-2 or any other severe ARDS, because the, you know, the ethics of doing that would be dubious at best. But those are my initial thoughts, at least.
This is Tim down in San Diego. I've actually been really involved in a lot of this. We made a transition between a lot of these guys on nasal high flow, going from the ICU and then staying on the wards because our ICUs were so filled. And I think one of the issues with nasal high flow, I mean, the FRAT study suggests that that's a very good thing to be doing for people that are in hypoxemic respiratory failure for a number of different reasons. There was a significant effect on mortality and a trend towards avoidance of mechanical ventilation entirely, not just a delay in it, but an avoidance. But what we've noticed is that if people will crank up the FiO2 very, very high and kind of run people on the edge, then when it's time to intubate them, there isn't much of an opportunity to pre-oxygenate them for intubation. You know, so what we're used to be doing is using relatively non-high inspiratory O2 methods. Even 100% face mask isn't much inspiratory fraction of O2. And when the anesthesiologist gets there, he can jack up the O2 and get, you know, 100% for a while to allow him to do the intubation. But if on the wards, we are doing that anyways, and we wait until a person's desaturating on 100% nasal high flow, then intubation becomes very, very dicey. And if you're not in the area like that, then you've got a real problem. So we've had to do a lot of education with our hospitalist staff to say, this is a great, great tool, but you know, you're running on empty if you were there, and just be careful about that.
So let me, I'll make a couple of comments here, if you don't mind. Two major comments. Number one, the high flow nasal cannula, I do believe, is a very valuable tool in managing these patients in an effort to hopefully keep them off mechanical ventilation. I think if you're failing high flow nasal cannula, going to non-invasive ventilation is inappropriate. I don't think the NIV is going to help in a failing HFNC, and I think it's time to put the endotracheal tube in. And NIV, in my opinion, has a very limited, if any, role in the management of these patients. That's point number one. Point number two is once you get them on the ventilator, it's my view that this is ARDS, and we ought to manage these patients like we do other ARDS patients. We use the evidence base, we use the low tidal volume, low plateau pressure, and gauge PEEP on the degree of lung injury. And people who are espousing using higher tidal volumes, alternate modes of ventilation, really there's no evidence base supporting those non-evidence-based approaches. And I think you're going into risky areas. We ought to stick with what evidence has provided us over the last 20 years and stick with lung protective ventilation as we've been doing it in ARDS for a long time. I realize there are a number of COVID patients with this high compliance, low oxygenation status. Maybe they have more vascular injury, in which case maybe a lower PEEP is appropriate. But going to unusual modes of ventilation, going to high tidal volume ventilation, I don't think has any evidence behind it, and I don't think we should be doing it.
So I just want to jump in here. I'm Nita Kadir, Pulmonary Critical Care at UCLA. I'm the co-director of the MICU at Ronald Reagan. I would agree that I want to talk a little bit about non-invasive because I feel like I am seeing a lot of adverse effects from it when we're getting transfers from outside hospitals. And a little bit, I'm curious what thoughts other folks have about high flow in certain situations. So I would agree that non-invasive, I don't think non-invasive has much of a role in COVID, absent another indication. In general, my practice is if it's not going to be better tomorrow, I'm not going to initiate non-invasive today. And we all know at this point that these folks take quite a while to recover. Where I get concerned, and it's institutionally, it hasn't really been our practice to use a lot of non-invasive. We have used a lot of high flow, which I'll come back to. We have gotten a lot of transfers from our colleagues at community hospitals, and I'm hearing things like, this patient was on BiPAP for a week. This patient was on BiPAP for 2 weeks, and then they finally tired out and we intubated them. And I'm seeing so much barotrauma, and oh my God. And I don't think there's as much thought put into the potential adverse effects here because of somewhat of the vent narrative that Russell was referring to earlier. But what I think what's being under-recognized is that when folks are being put on BiPAP, there's not a lot of attention being paid to their tidal volumes. These folks have early ARDS and very likely are getting injurious tidal volumes on positive pressure ventilation and in early phase of ARDS, which is when we know that low tidal volume ventilation has benefit. So I feel like we've arrived here because of this narrative that vents are bad and vents will kill you. And at first I thought this was like a misconception among patients and the lay press, but I feel like I'm realizing more and more that there's I think some fear in our in clinicians as well that's sort of spilled over. So those are my thoughts on non-invasive. The folks we have gotten who've been on non-invasive for a week or so and have not tended to do well afterwards, which seems to be the experience of others who've commented. In terms of high flow, so we've been using quite a bit of that, and I think there's a fair amount of evidence to suggest its benefit at this point. So I think we're probably all familiar with the Flora-Lee trial, where they compared high flow, non-invasive, standard O2, and there's decreased mortality in the high flow nasal cannula group, although no difference in intubation rates. There's been a subsequent meta-analysis kind of demonstrating the opposite, though actually no difference in mortality, but decreased rates of intubation. But I think the body of evidence does suggest that there is some benefit to the use of high flow. Now, where I struggle, and I'm curious to hear thoughts of others, is those folks who are on that high end. So the folks who are on 90 to 100% high flow, but they're maintaining saturations, in the mid 90s, and they're sitting there looking comfortable. How long do you let that ride? My practice has been, if they're desatting with movement, that's when I go ahead and intubate them, as long as the work of breathing, I will let them ride if their work of breathing is okay, until the point where they start desatting with movement. And I haven't had any crash intubations in that setting. But I would love to hear from others what your practice has been on those high ends of high flow, and what your experience in practice has been in terms of how long you let those folks ride.
I was actually going to bring that up.
I will agree with you that if they're up in that 80, 90% range and they're doing okay, you might want to sit tight, but they start to look bad. I have a low threshold for intubating them. And again, to reemphasize a point I made before, I don't think trying to go to NIV at that point is a good idea. It's time to intubate. I'll make one other comment about something you said, and that is these patients with COVID, but it also occurs in other forms of ARDS and other forms of respiratory failure, sometimes have an impressive what I call a whip to breathe. And even on low levels of ventilatory assistance will generate really impressive tidal volumes, and creating the situation of what people have called self-inflicted lung injury, or SILI, S-I-L-I. And that's a real problem. And I think if they have bad lung mechanics or tachypneic, we need to look at this phenomenon and really think hard and fast about whether we should be suppressing them with either extra sedation or even paralysis when they're pulling 10, 15 mLs per kilo tidal volumes, even though we're only on low levels of assistance. So I think that is an additional problem. And it seems to be more prominent in the COVID population. Not sure why. Maybe it's because the COVID virus affects the central nervous system and the brainstem and the breathing regulatory pattern. But I think it's something we need to pay more attention to.
I suspect there is something probably COVID specific about it, but I think we are, like, as a profession, contributing to it, because I will ask people, well, would you have put this patient on BiPAP for a week if they had influenza? And the answer is universally no, that's insane. So why are we doing this for COVID? So our practice, there's been some change in practice because there was this early misconception that this is not ARDS and should somehow be managed differently.
COVID is ARDS.
I agree, 100%.
Christian, I cut you off, I think. Sorry.
No, I would rather hear you speak than myself. And I think, I'm happy you guys brought this up, because this was one of the questions we wanted to bring forward. And we're having the same debate. If we have them on high flow, they're at 60 liters, 80 or 90%, and struggling when they use the commode or move, that for us is sort of a clear indication to transfer over. And even then, for the record, we're meeting a lot of resistance from families, because especially if grandma or mom looks good and they don't want to put the tube in, or they have this whole belief from the news that by the time they're intubated, their outcomes are poor. We are getting a number of people who are not interested, but that's another story. But I'm sort of stuck with the patients who are on, 50 or 60 liters at about 50 or 60%. They may be satting okay, but their work of breathing is high, and you know, we have some fellows who believe in this ROC score. We have others who don't. You know, I'm starting to hear a lot of our residents present, you know, the ROC score is 3.2 and we need to intubate them. It's very interesting to see this gray zone. And I think very much as Carolyn wrote in the chat, we intubated early on, we delayed a while, and now we're trying to find that perfect subset that we need to intubate after approximately 1 or 2 days on high flow. And I'd love to hear what people have done, because we haven't found the sweet spot, and it's very practitioner independent. I tend to be more aggressive. Some of my colleagues wait a little bit longer. I don't know if that's the best way.
Well, I think if you put somebody on a ventilator and don't treat them right on the ventilator, you go with funky modes, you go with non-evidence-based strategies, the ventilator is a death sentence. But I think the ventilator run properly with appropriate lung protective strategies is life-saving.
Can I make a comment here? But for my experience, this is Catherine Sassoon. My experience in the ICU lately with this COVID, after a high flow nasal cannula for like a week, 10 days, and then patient get tired, we intubate him. When we look at the compliance is very horrible, very low. And in addition to that, as their physiologic dead space has just gone to the roof. So unfortunately, we at the VA that don't have the ability or facility for ECMO. So this is what I'm seeing is once they are so on high flow nasal cannula at 60, 40 liter per minute at 90, 100% saturation, my question is whether or not we really putting them on high oxygen toxicity. It looked like no one or very few of us that thinking about that, because even in experimental animal in awake sheep, the time course of O2 toxicity is like 96 hours. And that's just looking similar like ARDS picture. So I'm just wondering, there are so many things that we still don't know. What's the timing of the best or the optimal time for the intubation? This is what really, we can pose this question to everyone, what you think about this. Although patient may look good, but we probably putting them on O2 toxicity.
Well,
Catherine, it's fun to hear from you. I haven't seen you in a while.
I know.
But I think you raise a very valid point. There's this reluctance to put people on mechanical ventilation because of early experiences in New York was that if you went on a vent, you were going to die. But I'm going to go back to a statement I made before. I think it's if you go on a vent and you're not managed properly, you are going to die. But if you go on a vent where PEEP can be used to protect you from oxygen, and sedation and even paralysis can be used to prevent self-inflicted lung injury, you're probably doing the patient a big favor. So it's unfortunate that there's this incredible reluctance to put people on ventilators with PEEP and with even paralysis or sedation to protect their lungs. And I'm hoping the pendulum is swinging back towards what was more traditional management before COVID.
Yeah, I agree. You know, if they look good and on high flow nasal cannula, I think we can wait. But the question is how long, right, before O2 toxicity set in addition to, because this O2 itself can cause oxygen radical, oxygen stress, oxidative stress, and on top of the COVID cytokine release or inflammatory inflammation in the lung. So, and then plus the microthrombi. So all that added to the high physiological dead space that I see all these patients, and it seems like a death sentence when the patient already on like 7 to 10 days on high flow, and then it get intubated, and then their lung compliance is horrible with that CO2 also just went to the roof. And when we have no ECMO, that's really depressing. And we still have no solution on the right timing for the intubation. Perhaps it's a good timing for like a multi-center study to look at, maybe after 4 days on high flow, if the O2 saturation cannot be reduced, then perhaps that's the time for intubation. I really don't know what's the answer.
Well, again, I want to go back and emphasize that I think a ventilator, especially with PEEP, can be very helpful in managing these patients. And we need to get over our reluctance to put people on ventilators, because experience early in COVID with inexperienced people using bad protocols did produce poor outcomes. I think the ventilator can be an important tool in protecting these patients' lungs.
Yeah, I completely agree with you. And plus the prone position is the
Absolutely.
only one, right, that has been shown very useful in terms of managing this, particularly in the early stage. So, and then if we have a dysynchrony, we have to use paralysis. We have to do that. Unfortunately, there's no other choice sometimes.
Well, thank you.
Catherine, this is Rich Branson. Good to hear from you.
Hi, good to hear from you.
So I see one of the things in the chat is about this issue of happy hypoxics. And I know that Neil, once upon a time, was a flight surgeon, but I think this is something that has become, like the fear of the ventilators. It's really a physiologic issue. I don't know that these people are happy. It's that they have hypoxemia as measured by the pulse oximeter, but they don't have tissue hypoxia because they hyperventilate, shift the oxyhemoglobin dissociation curve, and increase their cardiac output. So, from the very beginning, we heard these stories. Oh, they're very happy and they're not, they don't seem to be short of breath, but their O2 sat's 85, but all of a sudden they crash. Well, the crash is the point where their compensatory mechanisms fail, and then they progress to tissue hypoxia. But I don't know, Neil, is that something you guys have seen? That seems to me,
yeah.
Again, I think it's a word that people heard, happy hypoxics, and said, oh, we see that too. But sometimes I think it's because people aren't used to seeing that kind of low O2 saturation. Again, I go in the altitude chamber to 15,000 feet, my O2 sat's 83%. I don't breathe, I might breathe 4 times a minute at a 2-liter tidal volume, but I'm in no distress at all. It's just a different physiology.
Yeah, I mean, I don't think people appreciate this, but hypoxia in and of itself does not really produce much dyspnea. Yes, you'll get tachypnea. What produces dyspnea is the altered lung mechanics and the altered stretch receptors and the proprioceptors in the lung. Hypoxia in and of itself is not particularly uncomfortable. So if you get a phenotype of ARDS where the compliance is not bad, that is, the mechanics are not bad, but you have bad VQ matching, maybe because of vascular involvement by COVID, you will have a situation where you have horrible hypoxemia, the compliance is not bad, and the patient doesn't look particularly uncomfortable. So this is not an unexpected finding. It means that they do need support. It means that they do need supplemental oxygen. But the point is that this is a situation that is not surprising, at least to me, and we've seen it in other forms of ARDS as well.
Neil, do you think that's because, again, this is out of my league a little bit, but that there's so many of these patients who have a lot of microemboli and it's vascular VQ mismatching, and that, again, that's why the hypoxia is real, or the hypoxemia is real, but the lung mechanics haven't deteriorated.
Yeah, I mean, this has been postulated by a number of people in COVID, that the vascular involvement is more pronounced than the alveolar tissue interstitial edema inflammation. But that doesn't mean they don't need our support. They need ventilation support. They need supplemental oxygen. It's real.
And there's a question about helmet Cpap. I mean, it's not usually available in the US, and it's a lot harder than using the one you use in hyperbaric chamber to try to use it for a ventilator. I don't know if you guys have done it or not.
Yeah, I can't speak to that. I haven't had much experience with that device. It looks clever, and I've worn it, but I don't know much. I don't want to overspeak on this.
Well, Asha?
Yes.
Yeah, I was going to say, maybe one of my other questions was about extubation versus intubation and compassionate use of ourselves when we do that. And I'd love to hear our experts talk about that, because I'm caught up in that right now in the script system, trying to design something that is the right thing to do for the people. And so, any thoughts about compassionate extubation?
I think Dr. Hendrickson,
Yeah.
I'm gonna put you on the spot there. Thank you for joining us for that.
Sure. I'm Carolyn Hendrickson. I'm the co-director of the medical ICU at the San Francisco General Hospital, which is our county site under the UCSF umbrella. And we've taken care of more than half of the COVID ICU patients in the city just because of the overlap between the most vulnerable patients to the disease and the patients that we serve as the safety net hospital. We have an established protocol for transitioning to comfort-focused care that uses compassionate extubation for all patients who are transitioning to comfort measures, unless there's a pressing reason not to do that. And so we're using that same approach when we move towards palliative care goals in our patients with COVID, ARDS, and prolonged intubations. I have to say that one of the key parts of implementing this, which is really hard to do when everyone is so tired and working so hard, is that we talk to families every day as part of this checklist that we've implemented. And we actually increased our staffing, which I understand is a luxury, to accommodate at least brief family meetings with every patient's surrogate decision makers every day. And we changed some of our staffing to bring in this swing shift so that the continuity providers could have these conversations and not go home at 10 p.m. So we, I think, have an established rapport, and, you know, families understand that we're working really hard. And then some of the patients who are on the ventilator for such a long time, they've heard, you know, in many conversations that things are not going well and that we're trying X, Y, or Z and it's not working. And so when we do get to the point where we're recommending focusing on comfort and that recovery does not seem to be possible, in my experience, families have been very receptive to that. One of the things that helps us also is using these Zoom tablets, and we have family members doing video chats, even when their loved one is sedated or paralyzed or prone, because they're not seeing them in person as much as we'd like them to, for obvious reasons. It doesn't come as a shock to them when you bring this topic up. We are also allowing visitation for end-of-life discussions. And so family members, of course, aren't allowed in the room with their loved ones, but can see them from the adjacent ICU bay or sometimes the ICU hallway, which is not ideal, but you know, we're doing the best we can to allow them to at least understand the experience that their loved one is having. And I would say most families receive the discussion well. Not everyone wants to transition to comfort-focused care. And somewhere around like 30% in my estimate say, I hear your recommendation and I need them to die like this. Like I can't extubate them. I can't withdraw care. I need you to try everything and really prove to me that they weren't going to turn around. But most families that we've recommended it to are accepting of the recommendation. The nuances for these patients compared to a different kind of ICU problem usually involve reversal of neuromuscular blockade. We use a lot of rocuronium, and so we give Sugamidex before transitioning to comfort-focused care to make sure that we can assess signs of discomfort or dyspnea in these patients who have been chronically critically ill. And so that's the only, I would say, really different part beyond managing family dynamics of how we approach palliative or compassionate extubation. And then we tend to turn off the vasopressors, other supportive therapies, coming off first, Sugamadex. When their twitches are back, we get their opiates and anxiolysis prepared, extubate, and then turn off the vasopressors after that, so that there's sort of a more controlled end of life experience. I would say that the staff actually feel very good about providing end of life care in this way. And there's a lot of moral distress around coding someone who hasn't been responding to weeks of maximal therapy. And so I would say the physicians, nurses, and RTs really do feel like this is a better way to take care of someone. And I think families also can, for the most part, understand our position and see that we're still working hard to take care of their loved one, just in a different way. So I guess those are my major thoughts on this topic, but I'm happy to open it up or field any questions or answer questions about what we're doing at San Francisco General.
So I guess one of the things for me is, so the specifics of how you do it, I mean, are you have the family somewhere close during this time where they can actually see the event?
We offer that to them. Some people don't want to be there, and we say, like, I will be in the room with your loved one, they won't die alone. And some families don't want to see it, and some families do want to look through the window. They're not, our visitation policies do not allow them into the ICU bay for infection control purposes. And because of the way this virus affects family units, they also have to pass the screen for visitation. So like if they're COVID positive, for example, they are not going to be able to come in person because they put other patients and staff at risk. But you know, if those criteria are met, yes, they do come and look and witness their loved one's death.
Our conversation today also, I thought was interesting, was that the utilization of low flow O2 post extubation doesn't offer anything and doesn't really change the perception to the patient. So the idea was to go to room air. Is that what you do?
Yeah, part of our goal is to remove invasive devices and monitors to make someone look as much like themselves as possible, because, you know, the way this has played out for us is really that the patients are often not lucid, or, you know, we don't perceive that they're experiencing their environment. So it's, you know, we're attending to any signs of discomfort, but a lot of it is making sure that the family you know, recognizes their loved one as much as possible in the state they were in prior to this illness.
There's a question Dr. Hekier posed, is the futility of resuscitation in this patient population. You know, you mentioned that there's that 30%. And I think this is a great segue to Dr. Lowe's input as well on that.
Can I just say that for the patients who do say, or for the families who don't say, like, or say we don't want comfort focused care, I still tell them, you know, we're going to allow for a natural death. And I change their code status without saying, do you want me to do everything and do chest compressions and all that? I just say, you know, we can continue what we're doing, but if their heart stops beating, we're going to allow a natural death.
First, let me just say that hats off to all of you, because you're doing exactly what the most important things are. One, trying to manage the patient in a way so that they won't get intubated if they don't need to, but they will get intubated if they do need it, so they'll have better outcomes. And I think at the other end, what Dr. Hendrickson just said about patients who really aren't doing well despite sort of maximal intensive care, having those conversations and trying to have the family agree to a recommendation to withdraw therapy. I would strongly agree with not asking them to agree to no CPR, but to say that you will, if their heart stops, allow them to die as dignified a death as possible. So to say, at a certain point, the focus really becomes however dignified and humane the death can be, because it's out of your hands. I suppose if the family absolutely insisted, then you get a real dilemma. And I know that that sometimes happens, and sometimes people do get CPR, even though the whole team thinks it's not medically appropriate because of some family insistence or some other indications. But let me just, I have just a couple of slides, so don't worry, because I know I'm just standing between you and dinner. So let me try and share my screen. So the first thing I want to say is that I was asked to talk about policies regarding triage and allocation. And the most important things are, first, to do everything you can to prevent the need for triage. So managing patients efficiently, getting people who are going to survive off the ventilator as quickly as medically possible, and then trying to transition to comfort care where things are really not progressing. What I do want to say is that it's important to have a crisis standard of care in place before the crisis actually occurs. And I imagine those of you at referral centers probably have that in place already. But we know from what the state officials say that there are many hospitals who still don't have a policy. And basically, if, God forbid, we're actually in a situation that apparently we've avoided from what you said at the beginning, where there really aren't enough ventilators to go around, despite everything you've done, that it's too late then to develop a policy and to have people understand it. So let me just say that there are just 4 key features of a triage policy, and I'll try and keep it simple and short. 1, if you need to triage, that should be done by a triage officer or a team, not by the attending physician. That frees you up to really focus on the individual patient in front of you. Second, a policy shouldn't have categorical exclusions. Earlier sort of first generation policies often had provisions that if you have this, 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 or that, you're not eligible. The current thinking is that first, many of those exclusions were discriminatory, and there's a lot of pushback from patient advocates, disability advocates about those kinds of exclusions. Some of them are actually, frankly, illegal in terms of running afoul of federal anti-discrimination policies. And a couple of state policies were flagged by the Office of Civil Rights and had to be changed. Second thing about no categorical exclusions is that a policy that assigns scores and assigns priority depending on, assigns ventilators based on the supply, allows you to live with the changing supply of ventilators. So it's more flexible. Most important thing is to use an objective score like SOFA or modified SOFA to predict in-hospital survival. And I know there's a lot of discussion as to how valid SOFA is. And again, we're trying to just put people into, say, 4 categories is what the California policy is, based on physiological parameters that are easy to measure. There will be tiebreakers, and as a tiebreaker, California articles we've written recommend that you next go to comorbidities that limit short-term survival in 6 months to perhaps a year. There were earlier proposals to take into account life years, and colleagues of mine and I actually wrote some of those. We've changed. I really just want to focus on short-term, so in-hospital survival first, and then near-term survival. Let me just end the formal remarks by talking a bit about ethical issues, and you've already nailed these. In the context of patients isolated from their families, as Dr. Hendrickson so well described, it's really hard to shift to comfort care as the goal. And she kind of focused more on the implementation of palliative or comfort care. But as you all know, those discussions of bringing the patient along, discussions with the family are difficult in the best of times, even harder now where you don't have the face-to-face contact with the family in the room with the patient. And then Dr. Hendrickson already talked to you about the compassionate care of the dying patient. And the anecdotal evidence we have from families is that they really appreciate at the end the sort of the human presence that you or your team provide. Having someone hold the patient's hand as they die. They're very moving reports about trying to play the patient's favorite music or singing a song, or it may be appropriate to share a prayer, but to give the family the idea that you did everything possible under very difficult circumstances, but that didn't necessarily include doing more and more medical interventions in an unlimited way. And I just wanted to raise an issue which you folks deal with every day in your staff and yourselves. The terrible stress that all this has caused, the long hours, the really nonstop high patient loads. We're now beginning to appreciate, I think, that there are lots of ethical issues about the mental health of the providers. I actually think there's a twist to that, and there have been reports of that being worse in institutions where the staff doesn't feel they've been appropriately supported. Earlier on, there were lots of concerns that they weren't getting appropriate PPE, for example, there were shortages. And now I think the whole question of burnout is real, and I think you're facing it. I was very impressed with how you all were talking at the beginning about the vaccine and how the ICU surge has plateaued and it's gone down. You've got capacity now. And certainly it's great that we have several vaccines now and they're starting to roll out. Hopefully they'll roll out more efficiently. But we're not out of the woods yet. I mean, someone said earlier on that she wasn't a half glass full person. So if I tend to see the glass as mostly empty, we don't really know what will happen with these vaccines long term, whether some of these variants, particularly the South African variant, will be responsive, whether we can tweak the mRNA vaccines fast enough to keep up. So we may be getting to the end of this COVID surge, but if not another COVID surge, there will be other disasters that you'll be faced with. So that all I can say is just keep doing the wonderful job you're doing. Share your questions, your concerns, and your knowledge and experience with each other. I thought it was great to see you say, I really don't know the answer to this. I really like to hear what you're thinking. Or we thought one thing earlier on, and now with more experience, we're wondering if we went too far that direction and now we're going too far the opposite direction. So let me just end there. I know the hour is late, Asha, but if there are questions or if people want to email me, that's fine too.
Thank you.
I do have a question or a comment about that we've gone through. I think everybody's gone through this, and it's a very painful thing to even be considering. And that's not to say that we shouldn't be considering it, but an issue here in San Diego is that we have a dozen different hospitals here, and we are unable to do that sort of prioritization on every patient in every hospital. So what do we do about if the next person coming into our emergency department may not be okay may not have room for him, maybe another hospital does. And how do we make an ethical decision about that? Does that person do we not give the ventilator to the sickest person in our hospital or the sickest person in San Diego?
That's a great question. So I think one of the things that we may need to do is start thinking more of ventilators as being a regional resource. So from the other point of view, from a hospital who's overwhelmed and has a patient who they just don't have room for, can they find an open bed that's ICU staffed at a local institution and transfer? There've been some really nice, and this didn't happen earlier on. And I think, again, someone was saying that the New York example really colored how we think about this, because it seemed clear that despite close geography, the safety net hospitals that were overwhelmed weren't able to access beds in other hospitals that had capacity. But Dr. Morris, to answer your question, I think that's what the triage team at your institution has to do in contact with the other hospitals. That it's not just because you're the referral hospital, it's not just the people coming into your emergency room or getting sick on your wards, but you want to have some reserve for transferring people in. I don't know if that helps or not, but working out those personal connections in advance, as I'm sure you're doing with the other ICU directors at your local hospitals, just so you're all on the same page and that you're using similar standards. One of you doesn't have a kind of an outlier policy where they're intubating patients that would never be intubated. What you didn't touch on is the hard question of when do you extubate people when you're really overwhelmed? You have someone with a very good short-term prognosis, but really needs the ventilators. To go back to Dr. Henderson's cases, if you have a number of people on the ventilator who are really getting worse and worse despite maximal therapy, at what point then do you say, we need to give someone else a chance who hasn't been on the ventilator, who has a better prognosis? And that's a real difference, because what Dr. Hendrickson describes is what we do in ordinary clinical practice. We will continue, or not we, I don't do the same. You will continue people, but when it's really a public health crisis where someone with a very good prognosis, just there isn't a machine that they need to care for them, then it's really removing. That's really hard, and it's hard to do explicitly. They did it evidently in Italy early on when they had their surge. They didn't talk about it. It was a very European, Italian way. The doctors just decided, and it was terribly, terribly difficult for those of you who have colleagues there. For them to take that on and just make the decision was really hard. And that's one of the reasons in this country we try to be a little more explicit so that the public knows. I don't know if that was helpful. I hope it was.
Well, that's great. And I know we're getting close to 6:30. Denny, any questions on your end? Anyone else with some thoughts and topics before we close out? I think we turn into a pumpkin in a few minutes, Asha, I suspect. I don't know.
No, this has been amazing. Denny, any?
No,
concluding remarks.
It's nice to know everybody struggles and we all struggle together, because there's the same things that are happening down on the border as it is up north. So it's just good to know that we all struggle that way. Makes me feel less alone.
And to Tim's point, and I think this is open forum. We tried to develop ICU's Eyes in, coalition early on in the pandemic, because we were witnessing what was happening in Italy. And when these difficult conversations started to get to the forefront, where we needed public input and the political will faltered, and we were put on pause. So the conversations that we are now having as a whole state in this forum hopefully will offer us some connectivity. So if there's a ventilator available in Southern California, we can drive it to LA. And I know if Dr. Shankar is still on, I'd love for her comment, because I know in Kaiser, they were driving high flow nasal cannula tubing from San Diego to LA, and vice versa. So VG, if you want to just quickly make a comment.
Yeah, hi, thank you for the invitation to speak. Yeah, this is, in San Diego, Asha had led the effort to have good communication between different healthcare systems and create a coalition that could work together. Unfortunately, the political will faltered at the time when it needed to go out to the community for their input. We in the Kaiser system, of course, have the advantage of having a very large healthcare system, both north and south, and have been able to move resources both north and south as needed to support both our LA partners, as well as keep us afloat in Riverside and San Bernardino County. We've accepted patients in San Diego from other areas to help offload when our so-called northern partners in LA had their hospital systems overwhelmed. But yes, this could be much better organized if there was a greater political will.
So I guess on that note, I'd like to thank everybody. Thank you, VG, for sharing that information. I know we have a lot of work to do. I thank everyone for hanging in there, 15 minutes overtime, but this was a tremendously rich conversation all around. Any questions, please email us. Any thoughts for next week, please let us know. We are a membership organization, so a pitch for that if you guys want to join. I know a few people have enjoyed these meetings and they've already signed up, so we really appreciate that. And for next week, we'll powwow after we get some more emails and get another topic together. And if anybody wants to continue talking about crisis standards of care and maybe forming our statewide coalitions and alignment through this forum, that would be terrific. We could do it. So anyway, thank you all for participating, and I wish you all a good night and a good weekend.
Thanks, Asha.
Thanks, Asha. Thank you, everyone. Thanks, Neil.
Thank you, Asha.
Yeah. Oh yeah. Thank you, Dr. McIntyre, for it's a late hour, and all our panelists.
It was wonderful.
Really made it.
Thank you, Neil.
Pleasure.